Welcome everyone again. I am Dr. Fernando Verdugo, board-certified periodontist since 2003, researcher and published author. We're going to continue with the lecture series on how to prevent implant failures, bone loss, and biological complications. It is like putting the pieces of the puzzle together. This is what we're doing, integrating the knowledge so that we can understand why things happen and how we can learn to prevent such complications. The idea is to ultimately get good, healthy peri-implant tissues, stable long-term. These were some of the reasons that we discussed earlier on why implants fail. Basically, implants fail because of lack of integration, lack of new bone formation. There's definitely the microbial component. Infection can definitely happen. The prosthetic design is of paramount importance. We will discuss that today. And the excess of cement has been described definitely as a risk factor for such complications. These are two different cases of failing implants. The one on the left is a localized, the other one is a generalized case. They are both failing and they are different in a way, but similar. They share a common feature, which is both patients have been prescribed with multiple broad spectrum antibiotics throughout a number of years. We see that they both present severe bone loss. Radiographically, they both present severe bone loss and attachment loss on the remaining teeth for the generalized case. The generalized case has had a both maxilla and mandible full mouth rehabilitation. The only three teeth left are those that you see on the screen on the picture, 22, 23, 24. And so the proposed treatment for these particular cases is basically we need to understand why this is happening and we need to act quickly. If the treatment is to save the implant, we definitely again need to act quickly. There are surgical protocols for pre-implantitis that can be implemented depending on the bony defect and so forth. We will discuss that in future lectures. If we decide to remove the implant, then we definitely have to act quickly as well, because the disease site is basically the inflammatory response is creating more and more bone loss. If we decide to maintain, if the proposed treatment is to maintain the implant, then we can decide on whether to reconstruct that defect is possible or do a resective approach. Those are the two main protocols that have been described in the literature to treat pre-implantitis. If the decision again is to remove the implant, definitely my advice is to do a stage approach. And we will discuss what I mean by a stage approach. But definitely not doing anything is not going to help. This is a case, for example, of severe pre-implantitis. The patient had been with very deep pockets, 10, 12 millimeter pockets for years. This picture was taken 9 years after the implant had been placed elsewhere. You can see traces of biomaterial here and there. The proposed treatment for this particular case was implant removal. It is key to understand that the healing potential of these sites with severe pre-implantitis is not the same as fresh extraction sockets. When we extract the tooth, that site has a significantly much greater potential for repair, for bone fill, than a peri-implant defect that has been maintaining the situation of disease for many, many years. So this is the proposed treatment again for a case of severe pre-implantitis. Not all cases require implant removal, remember that. The proposed treatment for this case would be, I definitely advise a stage approach, meaning do not try to place another implant after removing the diseased one. When we have such amount of bone loss, it is better to clean out really well that site after removing the implant, degranulate really well, remove any traces of biomaterials that may be around the remaining osseous defect. Irrigate well the site with sterile saline solution. I would advise to wait a good 10 to 12 weeks, reevaluate clinically, and decide what to do. A CBCT is in order, definitely at around 12 weeks or so. Bone augmentation will come, this is part of the stage approach, will come. I would advise it to do it after, at this stage, after we have evaluated the CBCT data. Implant placement can follow thereafter after bone augmentation. And that is, again, the bone augmentation approach. It is something that we'll have to decide accordingly to your philosophy of work. I would definitely advise to do an augmentation protocol using autogenous bone. These cases must be followed up, of course, yearly, at least twice a year. And that is key to make sure that there's no signs of inflammation and the implant remains stable with healthy pre-implant tissues. This is another case of severe bone loss associated with an infection that the patient had at some point in the past. At this time, when I was asked to access those implants that had been placed by another colleague, there was no signs of infection. However, you can see the defect that had been created. The biomaterial apparently did not do the job of building new bone. And as a result, the site presented with a severe atrophy. In these cases of severe bone loss, I definitely advise, again, to degranulate well the site and wait. Take a CBCT. At this time, we took a CBCT 3 months after removal of those implants. You can see still that the defect has not healed properly. So I decided to wait after the first 3 months. I decided to wait an additional 5 months. And now we can start seeing some corticalization of that buccal aspect of the site so that we can do our augmentation procedure, which in this case was block grafting using a block from the ramus. These are different pictures from beginning to end. Severe defects, severe pre-implantitis can leave very nasty defects behind that may require significant augmentation. Remember to act quickly. As far as the infectious component and the case that we saw earlier, generalized, this was published years ago at the International Journal of Periodontist and Restorative Dentistry. There is definitely a risk of prescribing empirically broad spectrum antibiotics, especially for these pre-implantitis lesions. They harbor opportunistic pathogens, superinfecting agents that oftentimes have basically the ability to block penicillins, beta-lactamase. They have these enzymes, beta-lactamases, that can definitely block the ability of our antibiotics to do their job. And so these microorganisms have been evolving for years. And so as a result, they are very smart. They have become very smart. They basically can transfer those enzymes, the information to create those enzymes from cell to cell and among different species. They basically talk to themselves by quorum sensing, and they can transfer this information through horizontal gene transfer. So oftentimes, most of the time, the broad spectrum antibiotics is going to do more harm than good. We definitely need to stop prescribing antibiotics empirically, especially in this type of severe pre-implantitis cases. This particular case ended up, which was a referring case from a colleague that had basically been wanted to have an opinion on how to proceed. We identified by culture and PCR a number of superinfecting agents, such as enteric rods, yeast, and ultimately Agrobacter antinomyces concomitans, which, as you know, can cause rapid progressive bone loss. So the diagnosis was superinfecting agent-induced pre-implantitis. And these cases can be a nightmare, and we may end up losing all the implants. So we need to act quickly indeed. We're going to discuss some key aspects that could actually lead to, as well, to biological complications, the prosthetic design, and how basically we can prevent the prosthetic design from causing harm and bone loss. Briefly remind us what happens when a tooth is extracted. When a tooth is extracted, a blood clot is formed. That blood clot is key for new bone formation, which travels in an apicocoronal direction. Remember, the crestal aspect is always more fragile. When the tooth is extracted, we can have a process of remodeling, especially if we have a very thin buccal bone that can actually compromise the aesthetics of the buccal aspect. And this is more common, we can see more commonly on anterior implants. So definitely the crestal aspect is key. We need to do everything possible to enhance, boost that new bone formation at the crestal aspect specifically. And so especially if the implant, on top of everything, if the implant is placed in a not so ideal 3D positioning, the implant is placed to buccal, and you can see, such as, for example, the case that you see on the bottom, on top of the process of preimplantitis, the implant was placed to buccal, and that definitely led to aesthetic issues. The case on the top was done years ago, many years ago. Right now, it would be over 20 years ago by myself. The sites that needed augmentation, basically the patient had some infection associated with root canals on those lateral incisors that require extraction of both lateral incisors. So after augmenting the sites with blocks, we were able to place the implants, and the case was definitely successful, maintaining healthy bone levels and really good pink aesthetics as well. So the bottom line is, I want to emphasize that it's not all about the surgery. The surgery will not warranty a good surgery, meaning doing a nice augmentation surgical approach for a particular site is not going to guarantee that the final outcome, the final clinical outcome, will be successful. It depends on not only the surgical approach, but the prosthetic, the restorative aspect, which is key. They go hand in hand, and if one is not there, the other one will not allow proper aesthetics. So both are key, the surgical and the prosthetic aspect. These are two cases we're going to show briefly. The first case on the top is a case of delay implant placement. An extraction was done on the canine, a traumatic extraction that led to a severe atrophy. The other one is an immediate case, and both cases were treated following the principles of periosteal guided bone regeneration. This is the first case. You see the severe vertical and horizontal bony atrophy after a traumatic extraction of that canine. These are the defects. So following the principles of periosteal guided regeneration, we can address this site and decide whether or not we want to do a stage or a simultaneous approach. In this case, we decided to do a simultaneous approach. Definitely always evaluate well your CBCT data. This is the CBCT data showing the atrophy of the site of the canine area. So we definitely need to augment that buccal aspect in order to have an implant that is fully surrounded by autogenous tissue, by autogenous bone. So the case is compromised also because the adjacent teeth, both lateral incisor has a significant dehiscence on the buccal, as well as the adjacent premolar. You can see it also on the CT scan. That root is out of the alveolar process. So there is dehiscences on both sides, and there is a significant atrophy on the canine area. We need to handle this with care. The approach was to do a simultaneous implant placement and reconstruction. The patient was a good donor, had beautiful donor site at the tuberosity area. So we used that to harvest two cortical seals and particles to reconstruct the site simultaneously at the time of implant placement. And basically, those two seals were interlocked in the buccal aspect and surrounded by autogenous bone particles. This was published, a step-by-step was published in the Journal of Clinical Advances in Periodontics, which is an official journal of the American Academy of Periodontology. You can check that out at americanperio.org. And at uncovery second stage, we're going to place our incisions more towards the palatal and bring that keratinized tissue. We're going to push it buccal using our provisional. The provisional phase is key. It's key, and it should be mandatory on every single case in the aesthetic zone. So again, that smooth convex profile is going to push the keratinized tissue towards the buccal. And basically, I only do the surgical approach. I don't do any restorations, but we need to be watchful. As a surgeon, as a periodontal surgeon, I always like to bring the patients for follow-up and make sure that the crown, the implant supporting restorations are healthy and are not basically putting any pressure on the augmented sites. This is one of the key aspects, and I believe that will make your cases successful long-term. So what I identified on the restoration number one basically was a ridge lap. Apart from being a cement retained restoration, it had a tremendous ridge lap. It took me a long time to get from point A to point B, basically from picture 1 to picture 3. But definitely being able to identify the presence of a ridge lap was a key aspect in the final successful outcome. So basically, this is what happened. The first restoration that had a ridge lap looks something like this. There is plenty of documentation of research showing basically the importance of the prosthetic design on the final outcome. Basically, a ridge lap will not even allow us to probe that implant. So definitely, this is a restoration that should always be avoided on any implant, especially more so on anterior implants because the tissues are more fragile. So that ridge lap, this is, pay attention to these pictures because you can see it more clearly in these ones. The picture on the left, number 1, presents the final restoration with the ridge lap. And when I found out, basically I saw that there was signs of inflammation already, and it was a trapping food as well. These ridge lap restorations are not hygienic and will inevitably cause biological complications, inflammation, pocket formation, and bone loss down the line. So you should always avoid them. Again, that type of restoration, you can have an idea that basically the ridge lap is sitting over the augmented tissue, over the keratinized mucosa. Once that restoration was removed, we see the improvement. Now we can see our keratinized mucosa that has increased. It was there to begin with, but it was being smashed down by the design of that ridge lap restoration. So avoid them by all means. It will definitely increase the longevity of your implants. And again, to get from before and the after point A to point B, it took us a while. It took us a while already to do the augmentation, but also to finally basically allow or convince the restorative dentist to change the restoration from one to another. This is key. We need to, as surgeons, not only focus on the surgical aspect, but we need to make sure that the restorations are healthy and are basically providing or enhancing, boosting that peri-implant tissue health. You can see that both right and left pictures, the patient had on the right a diastema, so it would have been okay to leave a diastema on the left as well, but the restorative dentist decided to close it, which is fine, as long as we don't have that ridge lab, and we have basically a cleansability, a smooth profile with an ovate profile. That is definitely the key aspect. So this is the before and the after. You see that now the canines are well aligned. They have good pink aesthetics as well. Again, took us a while to get from point A to point B, but finally we got the desired result. If you're liking what you see, please, I will ask you to subscribe. There is more information coming up, and you can follow me as well on Instagram. The second case was basically referred for pain. The patient had a significant discomfort on a regular basis every time she ate, and there was a significant pain at palpation as well on the buccal aspect of the right central incisor. That is called, the radiograph you can see is the bull's, the famous bull's eye. So what happened was that there was a tremendous delaceration, a tremendous angulation of the apex of that root that was causing a dehiscence on the whole buccal aspect of that central incisor. So this usually happens during the developmental process when the tooth is forming, and usually is considered, it's not relatively common, but it can happen as a result of trauma. So that is, those are some pictures of the central incisor of the delacerated root, which was causing, as you can see, the pain, the severe pain on the buccal aspect. The patient was sent to an endodontist to see if they could do a root canal, but that was not possible. So the decision was to place an implant, extract the tooth, and place an implant, which this is what we did following the principles of periosteal guided bone regeneration. The buccal aspect, as you can see, there was a significant dehiscence, 10 millimeter dehiscence in the buccal aspect. So we focused on reconstructing that buccal aspect at the same time of implant placement, using, again, a seal, cortical seal, and autogenous bone particles that were harvested from the tuberosity area. These were some clinical pictures. And at the time of placement, the cortical seal is in place with the particles. The patient healed fine, the defect healed beautifully, and these are the different radiographs at second stage and 12 months. When I look at the 12-month radiograph, I see that there is something wrong, something that I don't like. So the patient did not have had a provisional phase, which is key to allow to basically build and guide the tissues for proper pink aesthetics. This was the final restoration delivered. And we see, remember the previous case, this is exactly the same. This is a huge ridge lab that is causing a tremendous pressure over the augmented tissue, and is basically hiding and sitting over the keratinized mucosa. So that restoration must be removed. Definitely my advice was I communicated with the restorative dentist to remove that significant huge ridge lab as soon as possible and replace it with a smooth convex profile restoration. So again, remember, we don't want this type of ridge lab restorations. They attract plaque and food. We cannot probe our implants, and they will inevitably lead to biological complications. The patient was happy and was young. Nevertheless, she was again sent for replacement of that ridge lap restoration. So all in all, wrapping up, it is not all about surgical excellence and performing a beautiful surgery or beautiful augmentation. The quality and the design of the implant-supported restoration is key for the longevity of our implant sites, and is also key to have healthy and happy peri-implant tissues. The main goals, and again, how we can prevent these biological complications. Well, number one, I want to have my implant fully surrounded by autogenous bone. I want to improve the bone to implant contact. So in doing so, I'm going to make sure that the whole perimeter of my implant is surrounded by autogenous bone. Place your implants in native bone, if not possible, in regenerated autogenous tissue. Remember, antibiotics are not the best option when treating peri-implantitis cases, especially severe peri-implantitis cases. Severe peri-implantitis cases most likely will be harboring super-infecting agents that are already resistant to the most commonly prescribed broad-spectrum antibiotics. Avoid always, by all means, ridge laps, overhangs, shoulders. Examine the definitive restoration. Make sure that it has a healthy, smooth profile that allows for cleanability. That is key. Hygienic restorations of beta smooth profiles are key. So in order to discover that, we need to bring our patients back and follow them up to make sure that this is not happening. By all means, avoid the excess of cement. I definitely am a strong advocate of screw retain restorations. Whenever possible, a screw retain restoration is the best. Finally, I want to thank you again for watching this presentation. I hope you liked it. Please, again, subscribe if you liked it. And again, you can follow me on Instagram, and there's much more informational content coming up. Thank you.